until we get to the objectives. So by the end of the talk, I'd like you to be able to describe the mission and growth of the Office of Clinician and Faculty Care, to be able to describe the importance of boundaries in psychiatric practice and the difference between boundary crossings and boundary violations, and finally to describe the challenges of maintaining boundaries for OCFC staff and for all mental health providers. It's a lot to cover, but I will do my best. There's the code for today's talk. Okay, so before we get started, I wanted to refer to Dr. Roca's excellent grand rounds given in late September, caring for our own, minding the morale and mental health of our colleagues. This talk is in many ways a sequel to that, and the QR code on your right will take you to a YouTube video of the talk. This QR code will take, and which will be up on many of my slides, will take you to our website that includes a link to our web referral form, and so feel free to share that URL and that QR code with colleagues or with other folks who work here. Okay, this is my uncle, and he is taking a picture of me, taking a picture of him. It's a metaphor for the talk. So I'm going to be giving an update on the Office of Clinician and Faculty Care, and also talking about boundaries, and using these two subjects as lenses through which to view the other thing. Okay, I also want to point out that when we are talking about boundaries, we are also implicitly talking about ourselves, because we are in charge of maintaining those boundaries. And so, so the subject of the photograph is my uncle, but I'm the secondary subject, not in some pompous way, because all photographs are about the people who took them, but rather because he's pointing the camera at me. Okay, so just keep that in mind. The motivation for the talk really arises from experiences that I and my colleagues, both in OCFC and in the Office of Wellbeing, have had doing road shows, which are brief 15-minute talks about our program to all kinds of leadership groups in the institution. And during those conversations, it's usually 15 minutes of a talk, and then a couple of minutes of questions, and often the questions are expressions of concern about privacy and confidentiality. And our responses to those questions often are centered on boundaries and how we approach the idea of boundaries and how we maintain them. So first, I'm going to talk about the Office of Clinician and Faculty Care, give you some background, and just show you some very straightforward data about what we've been up to since July. Then I'm going to talk a little bit about boundaries. We'll review some definitions, including boundary crossings and boundary violations, and then we'll talk about some of those considerations, particularly as they apply to the Office of Clinician and Faculty Care. So the OCFC really was started in response to three interrelated problems. As we all know, caring for patients and working in an academic medical center is extremely stressful. Many individuals are, well, most people at Hopkins are experts in something. Very few people, it turns out, are experts in assessing the effects of the stresses of their work life on themselves. Chronic stress can lead to burnout and is also an independent risk factor for depression. And we know that clinical and basic science faculty, advanced practice providers, and nurses face barriers to seeking mental health care. There's some documentation in the literature for this that I won't go into. And the reasons for that are likely things like internalized stigma. If you're in a helping profession, it can be a little cognitively dissonant to ask for help. Providers outside of psychiatry, I think, sometimes see mental illness as evidence of characterological weakness. And there are very practical concerns about licensure or credentialing, about what line supervisors or HR might know about care seeking. So the OCFC was started really in response to these kinds of issues. It turns out there's a lot of support available at Hopkins. The Resilience in Stressful Events team, or RISE, is a peer support group that responds acutely when there's been a bad outcome. I gave grand rounds in the anesthesia department. Actually, let me do this. How many of you in this room have been involved in a RISE debriefing? Right. So I asked that question in the Department of Anesthesia, and nearly everyone in Herd Hall raised their hands. It's a striking difference. Anyway, okay. RISE is a wonderful resource. They respond quickly and all over the institution. The Johns Hopkins Employee Assistance Program, or JEEP, provides 24/7, 365 support, usually delivered by psychotherapists. It's available for families, it's available for partners, and even after you've left the institution, that support is available. Spiritual Care and Chaplaincy provides spiritual support to patients and families, but they are also tasked with providing support to staff. And finally, the Office of Wellbeing. My colleagues here, Lee Biddison, Carolyn Kumsty-Fowler, and Suzanne Brockman, do a wonderful job. They and their colleagues are tasked with understanding determinants of burnout here and providing support for programs that promote wellness. And in fact, the Office of Clinician and Faculty Care is operated by folks in our department under the auspices of the Office of Wellbeing. Our mission is to offer a confidential pathway for eligible employees to receive mental health support from experienced Hopkins providers. Eligible groups are nurses, advanced practice providers, and clinical and non-clinical faculty, as well as non-faculty physicians. So, for example, physicians that work for Hopkins at Johns Hopkins, community physicians who are typically not faculty. I should note that trainees are provided mental health benefits separately, so we do not take care of trainees. They receive mental health benefits through the graduate medical education folks. Tier 1 includes 6 visits at no additional cost to users of our program, and those tend to be focused on the present concern, on role induction, and on a careful assessment of what's going on so that we can make thoughtful recommendations going forward. But then ongoing care is available after those 6 visits if needed, either at OCFC in Tier 2, at which point we would bill insurance, or we can refer out. One of the most common questions that we get is, how does our program compare with employee assistance? And in fact, those Tier 1 benefits are meant to be a so-called second door into EAP-like benefits. So it's not unexpected that we've gotten these questions. So both provide confidential and voluntary assessment and management of psychological distress. We are staffed by MDs, a PhD, and our LCSWC. JEEP is staffed exclusively by therapists who are working at the top of their licensure. And as I mentioned, they are available 24/7, 365. Because we are a smaller organization, mostly operate during regular business hours, and we take care of, as mentioned, nurses, advanced practice providers, MDs, and other faculty. And JEEP will see any employee, and they will see them from any place in our enterprise. It's a very large catchment. Our catchment right now is folks who live or work in Maryland, and I've mentioned the tier system. One of the strengths of our program is that we can provide ongoing care if need be, so that if someone has gone to the trouble of sort of getting over that activation energy and reaching out for help, that they don't have to change providers after that benefit runs out. At Jeep, you have your 6 visits, and then you're referred out if you need ongoing care. In addition, we do some extra things. NETA is running mindfulness-based stress reduction groups currently, and we're thinking about doing some additional groups, and we are currently offering couples therapy as well. This is the team. I'm the medical director, as Jimmy mentioned. Dean McKinnon is the other psychiatrist. Netta Gould is our wonderful PhD psychotherapist, and Sarah DeRosa has been with us since November. She's a 14-year veteran of psychotherapy and has worked at Weinberg in the past as well. We're currently supported by Allison Craig, whose actual full-time job is supporting Bob Roca and Bernadette Cullen, but she's also helping us as well. Okay. It's important that we are an experienced crew. There's actually some evidence that junior providers have a harder time working with medical professionals, and I won't show those data for interest of time, but I think it's important that we've been here for a long time to be able to manage, to be able to be reassured that we understand what the culture is like here. When you start a program, you have to advertise it, and we've done a lot of outreach, and we'll continue to do so. When I say we, I've done a lot of this, but Lee Biddison, who's the Chief Wellness Officer at Hopkins, Carolyn Cumsty-Fowler, who's the Chief Wellness Officer at the School of Nursing, Suzanne Brockman, Sarah, a number of us have done various things to spread the news about our program. Typically, this is in the form of roadshows, as I mentioned. So we've talked to 15 different groups, including the advisory board, the medical faculty, the faculty senate, the APP advisory council, which is how our patient today got in contact with us, nursing leadership groups, and so forth. Karen Swartz and I have both given grand rounds in the anesthesia department. Bob and I have given these rounds. There are wellness events. I did an advanced practice provider wellness fair for a few hours one day, and Sarah and I are going to the emergency medicine 5K in a couple of months. I'm not going to be running. And importantly, to get granular, Sarah, and along with Suzanne and myself, at times have done unit rounds, so gone to nursing units to talk about the program, bring flyers and so forth. So let's talk about the flow through the clinic. So what you see here is that we're going to start here. We've done 94 referrals. We've had 94 referrals. The vast majority of those are self-referred. When we get a call from someone else, we explain that we only actually do self-referrals because we do want to maintain privacy and confidentiality very carefully. We will then coach the person who is expressing their concern to us to approach the other individual in a way that person is likely to find palatable, and then they call and ultimately are referred. Of those 94 referrals, 7 are in process currently. They're sort of between the triage and evaluation stage. 9 folks, about 10%, did not follow up to our initial response to the referral. So we've completed 78 intakes who've gone on to receive Tier 1 benefits. 46 folks are still in Tier 1. 8 have had their cases closed, so they had short-term issues that resolved. They did not require ongoing care. 28 folks moved into Tier 2, and that includes, and then another 8 joined who were already in care with Netta or Dean or myself, but are eligible, so they are part of OCFC now. What you can see from this diagram is that no one has chosen at the end of their Tier 1 benefits to be referred out for care. I think that's significant. Okay. So this is who has come so far. 50 or so faculty, 30 nurses, 13 advanced practice providers, and others, mostly from the School of Medicine, but an increasing number more recently, largely I think due to Sarah's efforts with those nursing unit rounds. We've had an increasing number of nurses who are employed by the health system, and then folks from regional facilities as well. In terms of the diagnostic breakdown, roughly a third of folks have a mood disorder, a third have anxiety disorder, and a third have other things, primarily adjustment disorder. Most of the mood disorder is major depression. Most of the anxiety is generalized anxiety disorder. Most of the referrals come either through word of mouth or these outreach events. And we try to get to folks very quickly. So the median time to triage is 2 days after referral, and the median intake time is 10 days, so about a week to 2 weeks to complete the evaluation. Reasons that folks self-refer include work-related stress and anxiety, things like interpersonal conflicts at work, transitions to new roles. Grief is a big one. Relationship difficulties in folks' personal lives. New onset psychiatric illness or establishing care for a previously diagnosed concern. So what we've learned so far is that if you build it, they will in fact come. That's reassuring and gratifying. And that we also need to continue to do outreach, which we will. Really two main next steps. We're going to add additional groups. So we're probably going to add a grief group, and if there are other things that you think would be of benefit to our colleagues, please do let us know. And we're also embarking on a formal QI project as well. Maybe I'll talk about that another time. Okay, so let's move on to talk about boundaries. Why should we do that? Well, it turns out that they're very important. On the right, you see a cartoon of a cell membrane. The cell membranes, of course, divide the intracellular space from the extracellular space. They are the very definition of a boundary. And a properly functioning cell membrane allows the physiology of the cell to function properly. But of course, we take that for granted. All of our sodium, potassium, ATPases are functioning right now, and we never think about it. And so I think the same could be said for interpersonal boundaries as well. A few time points to note. Boundaries are so important that they're in the Hippocratic Oath. Okay, so 2,400 years ago, before doctors were doctors, right? Or at the beginning of that endeavor, we were admonished against seduction of patients and exhorted to keep patient secrets confidential. That's in the oldest version of the Hippocratic Oath that's extant. We'll skip forward just a few years to 1847, which was when the first AMA Code of Ethics was written. In the 1980s and 90s, in response to the prior decades' culture, I think, there were a whole series of papers delineating the extent of sexual boundary violations in psychiatry and medicine. And this really established the slippery slope view of boundary violations, which I'll talk more about in just a second. And then in the 2000s, there was a little bit of a pendulum swing back and kind of a recognition that maybe rigid proscriptive models of boundaries were maybe not optimal. Okay, so a boundary is simply a demarcation between things or people. Clinically speaking, boundaries can be considered the edge of appropriate behavior. The trouble, this is a definition by Glenn Gabbard, which he says is parsimonious. It is parsimonious, but it leaves aside the whole issue of propriety, that is, what is appropriate behavior, and that's not defined clearly. I think it's appropriate not to define it clearly, frankly, because it's fluid, it's culturally determined sometimes, and so I think we have to not rely on simplistic definitions of what do you do, what's right, what's wrong. Boundaries can be either crossed or violated. Boundary violations are never therapeutic. They're always harmful to the patient. And they, of course, may also carry a cost to the practitioner, such as forfeiture of the license. Boundary crossings, by contrast, are, by definition, potentially anyway, therapeutic, but they're not risk-free, in part because sometimes when you're in the moment with a patient, it's a little difficult to know whether what you're doing is a crossing or a violation. Okay? So an important question, which there is no simple answer to, is when does a boundary crossing become a violation? So again, simplistic do's and don'ts, probably not a great idea. That can mask the culture-bound nature of some boundaries. It is very important to say that sexual boundary behaviors are always violations. That's unambiguous, I think. I'm happy to be simplistic in this regard. But for other kinds of behaviors or arenas, if you like, the context can include all kinds of things. The treater's orientation, so the way one conducts supportive psychotherapy is different from dynamic, different from behavioral. The kinds of things that you might say to somebody or not say to somebody really vary depending on your approach. The presence or nature of informed consent, the point in the therapy at which the behavior occurs. Do you know the patient very well, or are you just meeting them? The respective cultures of the dyad, I'll give an example of that shortly. And then environmental factors. So commonly there's this example, if you're in a small town or in a rural setting and you're taking care of someone, there's a blizzard outside, their car break. I don't know why, this is the example it's given. There's a blizzard and their car's not working, do you drive them home? And I think if you're in a small town or a rural setting, that is, I think the evidence is that's more likely to be thought acceptable. Whereas in a place like Baltimore, where there is something approaching a public transportation system, and certainly there's lots of ride sharing and so forth, there's probably never a need for that. Okay. So what are these areas? This is one list of possible sort of boundary violations or crossings that might happen, and I'm going to touch on each of them in turn. We'll start with sexual boundary violations. These are the most serious. They're the most clearly problematic. There's almost no data about any of this, but because of the seriousness of sexual boundary violations, it's probably the most studied. It's probably also the least common. So in the 80s and 90s, when these papers were being written, sexual boundary violations were noted to often be preceded by more innocuous boundary behaviors, crossings or less serious boundary violations. And so then there was the idea that we should really try never to have a boundary crossing or violation, because that might be then a slippery slope that would lead to more serious events. If you think about the epidemiology of that, though, in fact, really what you want to know is, of all boundary crossings, how likely is it that they're going to progress to more serious violations? And turns out we have no idea, but there's a clear sense that it's not straightforward, and that it's also fairly clear that people engage in boundary crossing behaviors quite frequently, sometimes with great benefit. Nevertheless, these 6 studies, as summarized by Gabbard and Nadelson in their review, show that both men and women in a variety of medical fields have reported sexual contact with patients, men more frequently than women, so anywhere from 3 to 12%, and women anywhere from 1 to 4%. So I think it's important to acknowledge that this does happen, and to be mindful that this is an occupational hazard of being in medicine. Okay, it's actually not the focus of the talk because it is uncommon, so let's talk about more common issues. The first is dual relationships. That simply means other kinds of relationships that coexist simultaneously with the physician-patient relationship. So examples are being someone's friend or business partner or colleague, keep that in mind, while also being their doctor, and by doctor, of course, I mean provider. So dual relationships risk impairment of objectivity or selflessness. If you have business interests with somebody, how can you possibly be objective about what they might need? How can you put their needs ahead of yours if you are sharing other goals together? This is especially tricky in the age of social media, because you may actually already be connected by social media to somebody and then they become your patient, given how interconnected we all are, virtually speaking. Interestingly, the OCFC actually trades a risk of having dual relationships. By definition, our patients are all our colleagues, so there's already a risk of dual relationship there. So we are intentionally raising the risk of that kind of boundary crossing for the benefit, the potential benefit of having greater trust, because we, the providers, understand the culture here, and we are easy to access. We take people's insurance and so forth, and so we are balancing the risks and the benefits in that way. There are also, of course, mitigating factors. We are physically located in the 550 building, which is somewhat far from the madding crowd. None of us work in consultation liaison psychiatry, for example, so that we are not professionally working out in the rest of the hospital where we're likely to encounter other folks. And we always engage in role induction with our patients to talk about, well, what happens if, we are standing next to each other in the line at Subway? And we talk about how to handle that. All right, let's talk about gifts and services. Small gifts can be benign expressions of gratitude. Hard to see what's the problem with that. It is difficult to know, though, what is in the patient's mind when they give you the gift and what they're looking for in your response. Because I challenge you to think of a time that you've given someone a gift and you weren't looking for something from the recipient. Of course, these can lead to larger gifts, a sense of obligation, maybe even hopes for certain kinds of interactions. One of my roles is as an eating disorder doctor, so I'm constantly confronting people about the behaviors that they're not doing or that they are doing. And it's possible that if I accept a gift from somebody, that the motivation there will be so that I'll be gentler on them or that I won't be as confrontational. That's not to their benefit. Larger gifts or even bartering for services, of course, only increases the risk. Cultural factors may come into play. I'll give an example of that in a second. And so we have to be prepared to set limits, but that can feel pretty uncomfortable. I love this mug. On the one side it says Freudian sips, and on the other side there's a cartoon of Sigmund saying, "When you say one thing and mean your mother." I got this gift from a patient who didn't really have much in the way of personality vulnerabilities. So I accepted the gift, but I said, "Look, I will accept this gift and I'm very grateful, but please never give me anything again." She said, "Absolutely, I won't." The next year she gave me a live fish. Alive, and she did it. She drove 45 minutes on the day that she didn't have an appointment. She dropped the fish off when I wasn't in clinic. I came into clinic, and our clinic coordinator, Tracy Farrer, looked at me. She said, "You better check your office." I said, "Why?" She said, "Just check your office." And there was this goldfish. Think about the expectations that now, there was a context, I suppose. What about Bob? There's a goldfish, and what about Bob? Anyway, but that hardly mattered, right? It actually conferred a bit of a burden on me, and then I've got to keep this thing alive, and if I fail, what does that mean? Anyway, we had stronger words. I really was fond of the patient, but I really explained that never, ever, ever, and then there were no more gifts after that. Now, I will say that, so I'm going to tell you about one more gift. This is so those of you who have been in my office may have seen a copy of this. It's actually, this is a depiction of the Japanese gods Raijin and Fujin. They work to bring the storm, the god of thunder, the god of wind. And I received a copy of this from a Japanese student who I'd been working with for a little while and who was returning home to Japan after his time at Hopkins. And this was years ago. And he gave this to me at our termination visit. That was a little bit reassuring. And it was not a gift from him, but from his parents. And I felt at that moment that I could not, that I really had to accept it, and that the risk-benefit of this boundary crossing was that lay on the side of accepting the gift. Let's talk about time and duration of appointments. Being late to appointments or keeping patients waiting while you're with others has meaning. It can breed resentment. There could be lots of feelings you're generating in your patients that you may not intend. Alternatively, end-of-the-day appointments might be seen by patients as having a kind of meaning. Oh, you're saving me from the end. This is the classic kind of slippery slope where that might lead to something more. Same with late-hour appointments. Interestingly, as a little bit of a counterexample, I've noticed that if I'm working on the eating disorder unit, we're doing an admission, we stay kind of late, and the patients see us walking out late. The next day, often they will sort of say, oh, you were here late, are you guys sort of tired, are you okay? But the sense of that moment really is that I think that they feel like, oh, we take our job seriously, we're working hard to care for all of the patients. And that has tended to be the issue there. The point is, we are generating meaning all the time, all around us, and our patients are doing that as well. Language is an important boundary area. So use of informal language is something that I have been known to use occasionally. May be perceived by the practitioner as this is just me being friendly or relatable. But by patients, it might be perceived as sort of sloppy or careless or overly familiar. It may have all kinds of meanings that I don't immediately understand. And interestingly, the risk of this may be higher in the OCFC because we share the language of medical jargon, for example. We talk about patients as medical providers. And so we have to be, I think, a little extra careful there. On the one hand, I use my first name intentionally because I am mindful that many of our patients, particularly early on, are somewhat uneasy about coming into care, and we are, after all medical professionals. So I do that very intentionally. Some folks will slip into calling me Dr. Redgrave later. Others will stay with Graham. That's actually fine with me, but it is intentional. But I am careful not to use language, for example, that over-identifies with the patient. I don't want to just assume that I know what the patient's experience is because I, too, have been occasionally stressed out by working at Hopkins. So let's talk about self-disclosure, right? That's really what that is. It can be a powerful tool for rapport building, right? Normalizing certain kinds of stress, prepping to give grand rounds, for example, or frustration with aspects of working at a large corporation. I'm sure no one in this room has ever felt any of those things. The risks include blurring boundaries, right? How do we, what kind of conversation is this? Are we colleagues? Are we doctor-patient? And making yourself the focus of the conversation, which is really not appropriate, and alienating the patient if you happen not to share values. So talking about politics with your patients now, highly risky, right? We're not going to talk about the physical exam in the interest of time. How about physical touch outside of the physical exam? Shaking hands. If you're delivering bad news, maybe holding hands or putting your hand on a patient's shoulder. I think those kinds of things are done more commonly outside of psychiatry. Touch can be humanizing and comforting. It risks making the patient uncomfortable. It risks reinforcing dependency needs, perhaps. And sometimes the patients may initiate it. So they might want to spontaneously want a hug at the end of a visit. I've been caught unawares, and you will be too. So sometimes you have to respond kind of quickly, but respectfully. This is important. Boundaries might be viewed differently by different specialties. I'm nearly done. The boundaries might be viewed differently by different specialties. So this is a survey of 1,563 primary care physicians who were asked, have you ever done these things? And then, how do you feel if you had heard that someone else one of your colleagues had done these things. And I just want to point out, 34% had given a patient a ride home, 34% had helped patients pay for medication, and 60% had cared for a personal friend. And then of these 6 behaviors, really the only, and the levels of approval for all of these behaviors were extremely high, with the exception of having dinner with the patient. Again, I think that, and the authors say, look, we put that one in there deliberately to sort of allude to sort of a romantic connection. And reassuringly, perhaps, on the one hand, this was the lowest, but it is striking. So again, for those of us in the OCFC, our colleagues in other disciplines may feel quite differently about boundaries than we've been taught to feel. We had a very interesting conversation with a senior administrator who was helping us with the program, who said, look, these are not, she was talking about tier 1. These are not patients, they're employees, who said very emphatically. And what was, and I was sort of taken aback. I'm a psychiatrist, these are patients, what's the problem? But she was correct. We cannot assume in tier 1 that distress is pathological. It might be sort of a Hopkins issue, for example. And we couldn't use EPIC for tier 1 if that was the case, because EPIC is for documenting patient encounters, and these may not be patients. So that's why we have the second electronic medical record system. It is our job to maintain professional boundaries, even when our patients are not yet patients or might become patients. And we have a chance then to do some role induction. Okay, quickly to conclude, the OCFC serves, I believe, an important role to a generally privileged but underserved population. It's critical to understand ourselves, our patients, and the structure of the clinic and the way that might affect boundaries. We must cross boundaries when necessary, but only with care. And the OCFC does some things to break down barriers to care, but that has some risks and benefits in terms of boundaries. And again, OCFC users may have different ideas about boundaries. Finally, I just want to thank all the people. This has been a huge effort by a vast number of people, my colleagues at OWB, my colleagues in OCFC, other leaders here in the department and around the institution. Many, many thanks. 1 minute.
Thank you, Dr. Redgrave. Really interesting issues, and it's great that you're giving this such careful consideration. It makes a lot of sense in this context. Let me ask you about a question which I guess you didn't exactly address, but I think it's very closely related to what you're talking about, and that is this issue that I imagine must come up fairly often, and that is this question about to what extent you're able to what extent the people who come to you, whether they be patients or non-patient, potentially patients, to what extent do they ask you, gosh, is everything I say gonna be totally and completely confidential? Or, but of course, you know my boss, or you know my department chair, or, you know, are there gonna be conversations about me?
Yeah, so I think we say, look, in the department, we've been caring for employees of Johns Hopkins for decades, and we maintain very, very strict levels of confidentiality, and we will treat you the way we would treat anyone in terms of confidentiality, which is that this is no one's business. We are obligated to breach confidentiality in issues of safety the way we would for anybody. And so during those road shows, I actually have a slide where we talk about that, and we'll say that, say that very carefully. And that's true whether they're in tier 1 or tier 2. We do not report back to HR, to line managers.
Mm-hmm, mm-hmm. Thanks. We have time for maybe a question or two. Anybody? Got a couple of hands. Dr. Wilson. Questions about licensure issues and what's reportable.
So So our duty is to our patient. Our goal is to have them be able to practice safely. We do not have dual agency from our point of view to the institution, though we are both employed here. That being said, whenever you're working with a medical professional who, if they are impaired, might be putting others at risk, we want to have that be part of the conversation. I think that's really important to get patient. So if a patient is pre-contemplative about their alcohol use, for example, we might really want to raise affect about that and say, aren't you worried that you're going to be drunk or hungover and make a bad decision? Now, most of the time, people are more worried about that themselves than, and usually they're not quite pre-contemplative in that way. One of the important things that's happened recently, and that's a process, is that Lee Biddison, say hi, Lee, has worked with others in the institution to change credentialing language. There's a foundation called the Lorna Breen Heroes Foundation. They have a project called All In, and they are working with state licensing boards to to reduce the burden of the language that one uses, so to move from have you ever to are you impaired now? Because the former had a deeply chilling effect on the willingness of providers to seek care.
Interesting. Let's do one more question, I think. Oh, Dr. Nestat.
Your response to both of those questions are really important, but you responded as if you're treating patients, and you made it clear that your employees, so confidentiality, duties, all those things are very different for employees than patients. How did you deal with that?
Yeah, so from a medical legal point of view, if you were to talk to the lawyers, which we've done, what they would say is, look, someone walks into your office, they're in distress, they're asking for help, they become a patient. So in fact, we are their doctors, but we are recognizing that there's a period of time where in other words, our fiduciary responsibility is to treat them as if they were patients, but that only raises the obligation on our side, okay? But it doesn't. But in terms of the clinical formulation of what's going on, that may be less about the individual. So, for example, an advanced practice provider came to me with basically what amounted to post-traumatic stress symptoms after being assigned to work in an area where she had had an unbelievably toxic interaction with an attending, and years ago, and where she had done all the right things. She talked to her supervisors, to people in the room. She had tried to get help.